But we are going online now. We're just going to move straight to Salome. Is it? Yeah. Salome Meyer is with the Cancer Alliance. She's contributing to the same conversation that we have been having, just slightly more focused on cancer at district level. So I'll hand over to you, Salome Meyer from the Cancer Alliance. And are we able to see you? I see your presentation, but I don't see your face. Are you able to show us your face?
Yes, I'm able to show my face. Good morning.
Okay, just so that thank you. Okay, good morning, Salome. Thank you.
Good morning to everyone in the room, and thank you for the opportunity to share my experience as a cancer activist in the pursuit of equitable cancer. Louise Turner from the Breast Health Foundation is attending the symposium in person on behalf of the Cancer Alliance. I have worked in cancer care for the last 30 years of my life. First as an advisor, then as an advocate, and now as an activist. Next slide, please. Apologies for that. So as Nelson Mandela reminded us, injustice anywhere is a threat to justice everywhere. Across Africa and in South Africa, we know this reality all too well. Where you live often determines whether you live. Cancer outcomes are shaped not by biology alone, but by geography, income, and health systems design. And I think the previous speakers have absolutely paved the way for what I am going to also share with you with regards to cancer. There is next slide, please. There is a fundamental difference between equality and equity. Equity treats everyone the same, and equity responds to different levels of need. And justice requires equity. The key question for us is, what is justice then for cancer patients? Is it fair that patients are sent away from a primary healthcare facility with only a Panado, just because the healthcare provider doesn't know anything?
Okay, let's see what we can do with that.
You have a problem?
Okay.
Can I continue?
Salome, can you hear? Yes, please do.
Okay. What is justice for cancer patients? Is it fair that patients are sent away from primary healthcare facilities with only a Panado? That's when a healthcare provider doesn't know anything about the symptoms and signs of cancer. Is it fair that cancer patients have to wait for more than 6 weeks for results, let alone for their treatment? We know that access to cancer care depends on the 4 pillars, and it's not only cancer care, but it's also all diseases. That is availability, affordability, the quality of care, and the acceptability. And for us, this should be across the entire cancer continuum, which is prevention, diagnosis, treatment, survivorship, and palliation. At the Cancer Alliance of South Africa, we apply a human rights-based approach to advocacy, which is evidence-based, transparent, and independent. We use our reports for solution-based advocacy. Slide 4, please. Next slide. To make sure that we are all on the same rap sheet, let me briefly describe the differences between cancer and other diseases such as HIV, TB, and diabetes, of which we've heard a lot this morning, that can be managed at a primary healthcare level. When we refer to a person that has cancer, you have to be specific. Cancer of the what? Each organ is a different cancer. There are more than 300 different cancers. Each cancer will be unique, as there is no one shoe fits all approach. There are different causes for cancer. These could be cancers caused by a virus, such as cervical cancer, caused by the HPV virus, and liver cancer caused by the HBV virus, and that's hepatitis B, that are preventable with vaccines. Then we have cancers that are hormone linked, such as breast and prostate cancer. We have cancers that are caused by environmental and lifestyle, such as lung and colorectal. Mainly, it will be the older generation that are affected by cancer. However, this also is changing as a result of a modern lifestyle of fast food, inactivity, and many other factors. We refer to the continuum of care that starts at primary prevention, with aspects such as tobacco control and vaccination, which is the discussion of prevention that Adishini shared with us. Awareness and education at a community level by health workers that work in communities and understand community challenges. Again, here Mohammed actually shared some of their experiences. Early detection at a primary healthcare level by healthcare workers that are trained, screening and diagnosis that is followed by treatment with supportive care as well as palliative care. Most of this happens at secondary and tertiary care levels. Cancer is also a treatment with more, or a disease with more than one treatment modality. It is not a matter of take your pills or your injection and then you will be okay. The treatment modalities of surgery, chemo, and radiation therapy requires highly trained specialists and equipment and chemotherapies that are expensive and mostly not even available on our essential medicines list. And lastly, after heart disease, it is the second highest cause of death in South Africa for non-communicable diseases. Next slide, please. I know the slide is quite busy, but let us just take a quick look at the burden of cancer in South Africa. The slide tells you about the top 10 cancers for males and females. Cancer is a registrable disease, with the National Cancer Registry being responsible for the management of collected data. It is, however, only a pathology-based registry, noting that not all cancers are diagnosed or confirmed with pathology. This leads to an underreporting, and it is estimated that there is a 40% underreporting, and also not all laboratories report to the National Cancer Registry. Despite all of this, in 2023, the latest available data set, which you have there on the screen, a total of 87,853 people were diagnosed with cancer. Now just add the 40% that is not actually recorded. We do not know the survival rate, as death statistics is not linked to the National Cancer Dataset. Survival rates are important as it tells you how good you are in managing your disease. With data sets that are incomplete, it therefore remains difficult to plan and to budget appropriately for exactly the cancer care that we would want to have at a district level. Next slide, please. The slide shows you the top 10 cancers for the different 4 population groups. And again, this underscores the difference between where you live will determine whether you live for most people. Just note the high incidence of cervical cancer amongst Black women. This is despite the fact that we have a cervical cancer screening policy in place for many years. But we also know, and this is at a primary healthcare level, and we also know that the policy implementation is severely lacking. If we reach 35% of our women, we are lucky. Breast cancer remains high. However, we also need to say that there is a lot has to do with awareness, education, and early detection. Note that non-Hodgkin's lymphoma is also associated with HIV. We know that a low immune system is a high risk for specific cancers. Next slide, please. The slide shows you the cancers in the male group. Prostate cancer remains our biggest concern in all population groups. Again, the differences between population groups tells us the story of access and specifics that has to be taken into account when we plan for cancer care services. Also notice the HIV-related cancers such as non-Hodgkin's lymphoma, corpusculosarcoma, and also cancer of the penis. Next slide, please. If we now focus on cancer care services, we know that in South Africa, we have one of the most unequal health systems in the world. 86% of the population uses the public sector and 14% use the private sector. Yet in oncology, 80% of oncology professionals service exactly that 14% that access the private sector. And that also goes for equipment. And hence we have a court case against Gauteng Health Department. Our incidence for cancer is increasing, despite the fact that we don't have appropriate data sets. But so is the cost as well. And it is projected that by 2030, we would require more than 50 billion to manage cervical, breast, prostate, lung, and hematological cancers only in the public sector. That's not even talking about any of the other cancers. Hematological cancers are of the most expensive to treat and could be managed effectively at a primary healthcare level. We only have screening for cervical cancer in place at primary healthcare level. The breast cancer policy was approved in 2017. However, this policy remains unimplemented in all provinces due to budget constraints. The prostate cancer policy was started, yet never completed. It means that our men goes without screening. A lung cancer policy is also in place, but not implemented. And the same goes for colon cancer. In fact, there's nothing in place. And what we also have as an added burden is that patients with stoma care, and that's where Russell's point of dignity comes in most provinces only have access to 5 stoma bags a month. 5 a month. That means for the rest of the time, you have to, as Faisal will call it, MacGyver a shopping bag. Treatment of cancer mainly happens at our tertiary levels. This impacts patients as rural patients have to travel long distances and often have to take leave or risk losing their work to stay alive. Next slide, please. Unlike HIV and TB, that was prioritized many years ago, with only one directorate that coordinate and manage this disease or these diseases, cancer is managed across many divisions at national and provincial level with no coordination, and it is not prioritized. Treatment guidelines are not standardized, which means that a patient in Limpopo will be managed differently than a patient in the Western Cape, which in any case is managed as a different country from a health perspective. Most patients in the public sector are diagnosed with late-stage disease, that is stage 3 to 4. These stages are difficult to manage, are costly, and also have a poor clinical response. Early detection with proper referral pathways will change the outcomes for patients and also for the country from an economic perspective. People with early stage disease can be active citizens contributing to the country's economy, while late stage disease patients will become a financial burden on the system and on their families. Most patients do not have the luxury of being treated in their own home language, as most clinicians are not conversant in the language of their patients. The word cancer doesn't even exist in many languages, and something like radiation therapy is difficult to explain. In some cases, it is translated as to burn. Now, how do you explain that? Treatment for cancer is prolonged, which does mean that patients have to balance their circumstances and cannot function properly. Ask any patient that has been on Red Devil for chemotherapy how they feel after the second round of treatment, and they still have to face many more. Your life changes completely, and most patients have limited or no palliative and supportive care, which means that they are left to their own or family resources, physically, financially, emotionally, and mentally. Next slide, please. To ensure that cancer is a district priority, our call to action is cancer must be recognized as a priority. The same political will that we afforded to HIV and TB must be afforded to cancer. We cannot have the situation of where you live, that we leave people unattended with cancer. When AIDS became a national priority, a National AIDS Council was established. Now we demand the same. Establish a National Cancer Institute, which will be coordinating body that will take the responsibility for equalizing the playing fields with standardized treatment guidelines between the public and the private sector, ensuring access to care using data systems effectively to project, plan and budget for cancer care, and ensure that healthcare professionals are equipped to manage the epidemic that is facing us. We can no longer afford to work in silos. We need to integrate NCDs and cancer in our HIV and TB programs. We cannot afford not prioritizing this, such as what happened in round 6 when the principal recipients of the Global Fund deprioritized cervical cancer screening and returned the money unspent to the Global Fund. And now, in round 7, we sit with the same inaction. No, this is unacceptable that we have this kind of attitude about people's lives. We need to invest in our community health workers and traditional health practitioners. They remain the foot soldiers in our community for education and awareness. And again, the focus should not only be on HIV and TB. Cancer screening should be included in the ideal clinic framework. That will require that we ensure that healthcare professionals are trained and that there are appropriate referral pathways for diagnostics and treatments in place. We can decentralize cancer care. It is not impossible. Medical officers at secondary level will make a world of difference. This should be coupled with surgical capacity for cancers that can be treated effectively at this level. Just this investment alone will save a lot of money in the future treatment budget. Our focus should be to improve survival and the lived experience of cancer patients and their families. We can change the outcomes. Last slide, please. In closing, there is a practice amongst cancer treatment centers to ring a bell when the patient has completed their treatment. Every patient wants to hear the sound of that bell and in fact want to go and ring that bell. It should not be something that is impossible. We still have much work to do. Equitable cancer is not charity. It is justice. It is a human right. And it is a shared responsibility. Thank you.